All right, so this is one of the most impressive x-rays that you'll ever see. This was sent to me by an emergency practitioner from another country without any clinical information whatsoever. So let's go through and break it down, and then we can deduce what we can about what was happening with the patient clinically. All right, now, at first blush, this x-ray should strike you immediately as being very abnormal. What should be jumping right out off the screen at you is all this black on both sides here. Remember, black on x-ray is air. So there's all this excess air here that doesn't belong. Now the question is, what's the diagnosis? A lot of you guys said bilateral tension pneumothorax. And while that can happen, these are not pneumothoraces. How do you know that? The key is to identify the diaphragms. Remember, when you're looking at an x-ray, it's like mirror image. So this patient is facing us. This is the patient's right side, and this is the patient's left side. So this thin, horizontal, radiopaque line is the right hemidiaphragm. And this one on this side is the left hemidiaphragm. And when we look above into the thoracic cavities, there's no pneumothorax here. There's air here, but that's normal air within the lungs. You see lung markings all the way out laterally on both sides here. There's no pneumothorax. Now you will notice that the lung volumes are small, and that's because the diaphragms are being smashed up against the lungs because the air that is here inferior to the diaphragms is in the peritoneum. This is pneumoperitoneum. And more specifically, this is tension pneumoperitoneum. Now, this isn't very common. It's a very rare phenomenon, but it will happen, and you will see it. And the causes are either a patient who has just undergone a procedure, so post-procedurally, or spontaneous. And if it's spontaneous, that means that there is rupture. There is a perforated viscus somewhere in the abdomen, whether it's the stomach or anywhere along the bowels. Now, this is a massive amount of air, and it's a bad sign when you can outline the abdominal organs, like the liver that you see here, the gallbladder, the stomach. This is the spleen, and there's so much air here that it actually goes off the screen, out of our field of view here. So this is a true emergency. This is a subset of abdominal compartment syndrome. Now, what do you do when you see this? Well, this patient probably needs to go to the operating room as soon as possible, but you got to do something, because this patient, even though we don't have vital signs, we can deduce, was in shock. You get compression of the IVC with decreased venous return, which leads to low cardiac output. This patient was probably having trouble breathing, tachypnic, very tachycardic, and you got to do something to temporize the situation. So what do? You do needle decompression, and it's very analogous to needle decompression for a tension pneumothorax. And essentially, you're doing a paracentesis, but for air. And as long as you're avoiding the superior epigastric arteries, which come down here several centimeters from the midline, you're going to be safe, especially with this much clearance. So you put the needle in either a 14 or 16 gauge with an angiocatheter, and you will get a lot of air. Attach it to a syringe with negative pressure, and if you put a little bit of saline in the syringe, you'll see bubbles, and you know you're in, and then remove the syringe, leave the catheter in, remove the needle. This is a life-saving procedure. Remember this: tension, pneumoperitoneum, be able to identify it when you see it and know exactly what to do. And one day you will save a patient's life.